So as we kind of gather, I'd like to just take a moment to say a word about the Integritas Institute for Ethics, what it is. It's actually an educational department of the St. John Paul II Newman Center here at the University of Illinois at Chicago. My name is Chris Saliga. I'm a Catholic priest, and I'm the current director of the Institute. And so I'd like to just, with that in mind, say how grateful I am to a number of people here at the College of Dentistry who have very significant backgrounds in bioethics and some even in theology. And we've achieved some good collaboration here, which hopefully is going to continue into the future, and we're going to be able to bring a lot of wisdom to the table that will be helpful. One of our collaborative groups is the Christian Medical and Dental Association. And so I'd like to now hand the baton to Elizabeth Gerardo, who is a dual enrollment student here at the college and currently presides over that organization here at the UIC College of Dentistry.
Thank you, Father Chris. As Father Chris said, I now lead the CMDA. And the CMDA's mission is to invite Christ's presence on campus in and through healthcare. So we meet weekly, and actually tomorrow in room 430C we will be meeting. And it's just a time to kind of escape the busyness of dental school and just share our faith and share ideas on how to get more involved in service activities and grow in our faith together. So I would like to introduce our speakers today, and I'll give you a little bit of a background of both of them. You know Dr. Roucka, but we also have today Dr. Rebecca Davis-Mathias, and she holds a Master's of Arts in Theology and PhD in Christian Ethics from Loyola University here in Chicago. She is a certified Last Steps Advanced Care Planning Facilitator and has taught and served in distinguished bioethics capacities for many years in both the United States and in Canada. Dr. Davis-Mathias currently serves as an adjunct instructor at Dominican University in River Forest, Illinois, where she teaches bioethics to nursing and other students. She also serves as an ethicist at St. Anthony's Hospital here in Chicago and a consulting ethicist for the Franciscan Sisters of Chicago Service Corporation and at the Integritas Institute Bioethics Board. Dr. Toni Roucka is a 1990 graduate of the UIC College of Dentistry and Associate Dean for Academic Affairs here. She is a Fellow of the American College of Dentists and immediate past President of the American Society for Dental Ethics. Dr. Roucka also serves on the Integritas Bioethics Board. While much more can be said of today's distinguished speakers, I gratefully present to you Dr. Toni Roucka and Dr. Rebecca Davis-Mathias.
Thank you, Elizabeth and Father Chris. Can you all hear me okay? So thank you for coming this afternoon and having this conversation with us. It's a difficult topic. But it's one that really touches all of us at one point in our lives or another. So we really feel like it's an important issue to bring to the table. And so I'm going to go ahead and start out with some nuts and bolts type of information. We're going to talk a little bit about informed consent and the basics of surrogate decision making. I have a video that I'm going to share with you as well. And then Dr. Mathias will talk a little bit more specifically about end-of-life issues. So we're going to go ahead and get started. So I would just like to show this slide here at first to just kind of take home the point that the population is aging, and it's aging quickly. And when we look at dependency ratios for the United States from 1940 to 2050, you can see how the shift is occurring in dependency from youth to those over 65 and older. And it's a very significant shift. And so if you haven't encountered patients already in your practice with issues with advanced directives and with competency type issues, We surely will going forward more and more frequently. So I'm going to go ahead and share this video with you first. And this is going to bring home a lot of the points that we will be discussing later on. This is from Stanford, and it's very relevant. So that video really does bring to light a lot of the issues that we have to deal with, as our parents age, as we go through things ourselves, and Dr. Mathias will go through how we might manage those things a little bit easier. So I'm going to go ahead and talk a little bit about the basis for all of this, and really all of this decision-making, surrogate decision-making, is really rooted in the concept of informed consent. So informed consent, as all of you know, is the process through which a patient is provided the information that they need to make informed, reasoned decisions regarding proposed medical treatment, and also issues like end-of-life care. So there is a very strong and rich history, a historical basis and ethical basis for the doctrine of informed consent, which we don't have time to talk about today. But those of you interested, I would encourage you to do some reading on the topic, because it is very intriguing and it's important in our healthcare history. But anyway, it really stems from the Nazi war crimes of World War II. At that time, there was no laws that governed informed consent. No laws were broken in those horrible experiments that were carried out in the concentration camps, because nothing existed to govern that. There were other atrocities, incidences of research issues occurring in the United States at the same time. So all of this really spawned the ethical principles that we know today, that we take for granted, and the doctrine of informed consent, and also IRB. So, one thing we have to remember is that after all of that, now in place, there are laws that govern all of this stuff. And so patients have a right to determine what is done to their bodies. And if we don't get consent from a person, we're actually committing battery. And so, that's the unauthorized touching of another person. So we need to think about that. Informed consent is extremely important in all that we do in healthcare. So it really is a collaboration between the dentist, physician, the healthcare provider, and the patient themselves, who take responsibility for their treatment and for a good outcome to be the result. It is not a paternalistic process as it was in the old days. It's a very shared decision-making process. And so the moral basis for the principle, or for informed consent, is the principle of respect for autonomy that we all, again, at this point, really in our lives, take for granted. So it's based in ethics, and it is part of our legal system, and it is also the legal part of the treatment plan presentation, the obtaining of informed consent. So in the process of getting an informed consent from a person, the diagnosis and the treatment plan itself really form the basis of the discussion. So enough information has to be given to the patient at any given time for any given procedure, enough information so that they can make an informed decision for themselves. So the amount of information given at any particular time should be what a reasonable person would need to know. And that's kind of legal terminology. What would a reasonable person need to know? It varies for the case, for that person at that point in their life, for the extent of the treatment plan and all of that. We could spend probably a whole day talking about informed consent. But that's basically what we need to know for purposes today. So there are really 5 elements of informed consent that need to be satisfied. A patient has to be competent, which means they have to have the ability to make decisions for themselves. We have to disclose the information, so there's that disclosure piece that's giving them that reasonable information, or the information that a reasonable person would want to know. They have to be able to comprehend the information, which is different than competence, and we'll talk about that in a minute. It has to be voluntary. They have to be participating in a voluntary way, and then they have to authorize us to do the treatment for them. So that is the verbal or the written authorization that occurs. So when we talk about surrogate decision-making, we're going to focus on these 2 aspects of informed consent today, because these are the most important for our purposes today. So competence is the capacity to make healthcare decisions, the capacity to make decisions for themselves. That means they have the mental ability to do so. So the patient needs to be able to understand the information that's being given to them. They have goals and values, and so that they can weigh the information and decide whether or not that they want to go through this procedure or have whatever it is done for them that day or long term. And the patient has to have the ability to make an independent decision. So they need to be able to speak with you and converse with you and come to a joint decision with you. So in order for a patient to comprehend what you're telling them, that could vary. So a patient who is a competent patient may not comprehend what you're trying to tell them in any particular situation. So think about that for a minute. There could be language barriers, like the one patient in the video. This person is a competent person perhaps, but there's a language barrier, so they're not comprehending what you're trying to tell them at that moment. If a patient is sedated or if they're under the influence of drugs, they may also have a difficult time comprehending what you're trying to tell them. General health may contribute to that as well. And you have to be careful and cognizant of patients who are in severe pain, because they may also not be at the point where they can really comprehend and understand what you're trying to tell them at that moment, because they'll do anything in their power to be out of pain. And so they may consent to something that later they might regret. And so comprehension is a little bit different than competence. So competence versus decision-making capacity. So competence is the legal term that's used, so it's designated really within the legal system itself. And decision-making capacity is a clinical concept, so that's assessed within the healthcare system. So you have to determine when a patient is in your chair whether or not they're understanding you when you're trying to explain something to them. So you determine that capacity at the chair side on any given day. And that can vary for patients on any given day. Also, patients have the right to refuse treatment, just as they have the right to consent to treatment. And as you know, when somebody does refuse treatment, refuse life-saving care, for instance, at the end of life, patients obviously need to know what they're getting themselves into, all the pros and cons, the consequences, and that. I'm sure all of you have personal stories, and I have one. My grandmother actually refused life-saving care at the end of her life, and that was very difficult for all of us. So she had the capacity to make those decisions, and she chose to refuse care, and so that's just as difficult as somebody who you have to make those decisions for. So we're going to talk about surrogate decision-making now, and then we'll lead into the end-of-life issues. So surrogate decision-making occurs when the person themselves cannot make decisions for themselves, and so it brings a third party into the picture to help make decisions for that person. So this is a paternalistic process by nature, but we try to respect the patient's autonomy as much as possible as we work through these issues. So there are two principles that are widely accepted within the healthcare community that correspond to surrogate decision-making for people in various cohorts. So there's the substituted judgment principle, and there's the best interest principle. So when we utilize the substituted judgment principle, what we're doing is we're trying to know what the patient would have done if they could make decisions for themselves. So another person's decision substitutes for the patient's decision. So this could be their spouse, this could be a legal power of attorney for healthcare, which we'll talk more about later. This could be a healthcare provider, an adult child, legal guardian, or caretaker. So with substituted judgment, this second principle, the patient was at one time, actually, I'm sorry, we're still on the same principle. This patient had to be at one time mentally competent or able to make their own decisions for themselves. So this is the only time we could really utilize this principle. Again, it's based on autonomy, but the patient is unable to make those autonomous decisions themselves at this point. This principle cannot be used for pediatric patients or those patients who were mentally compromised before the age of majority or from birth, because they never were able to make decisions on their own. So how do we know what a patient would have wanted, and how do we go forth with this process? Well, ideally they wrote it down. If they wrote it down for us, it makes it easy. They have done what's called advanced directives, power of attorney for healthcare, or living wills, and Dr. Mathias will go through all of these things in a moment, but that does make our life a lot easier if it's in writing. Another way that we could apply this principle is if they told us what they wanted. Anecdotally, we're walking down the street one day, and maybe there's a poster and there's somebody with a feeding tube, and this person tells you, you know what, if I ever get to that point, I don't want a feeding tube. That may be all we have, and if that's all we have, at least we have something. We have something that they told us. So that's the second best way that we can apply this principle. And the worst way that we could apply this principle is that we have to make an educated guess. And we do that trying to think about how that person lived their life before they became incapacitated and what we think they would have wanted. Not ideal, right? So, but it's all we have maybe, and that's what we need to work with. Looking at the second principle, this is the best interest principle. This is the one that's applicable to minors and those who have been disabled from birth or before the age of majority. So this principle is based more in the ethical principle of beneficence. So we're trying to do what's best for the patient at any given time. The patient couldn't tell us what they want, so we try to do what's best for them. And so, just by design, what is in the patient's best interest may not necessarily be what the patient would have chosen for themselves, but we don't know that. So we always err on the side of life in those situations for the most part, doing what's best for the patient. In the United States, parents and guardians are assumed to be the ones that are going to work in a patient's best interest at all times. They're the ones closest to the patients. But those of you who have worked in hospitals or even in pediatric dentistry, you'll know that sometimes that doesn't occur. And when there's a discrepancy between what the healthcare provider wants and perhaps what the parents want, we try to work through those issues at the chair side, but occasionally we will need to get a court order in order to move forward. So for instance, a parent refusing a blood transfusion for a child, the child needs a blood transfusion, we may need to go to court to make that happen. So only in cases of emergency can healthcare providers act against the parent's best wishes without court order. This is life-threatening type emergencies. And then we have to deal with partially incapable patients. And as the patient population ages, this is becoming more and more common. And so we need to deal with issues right at the chair side, determine whether or not a patient can make a decision for themselves on any particular day. When in doubt, we need to work with other healthcare professionals to make that happen. So this is causing more and more challenges for us. So the dentist's role in all of this, since most of us are dental folks in this room, we want to collaborate with the healthcare team to manage complex patients and deal with family members and such when we need to. We want to understand what patients may be going through. So hopefully this talk will help with that. And then we want to be familiar with these concepts so that we can benefit ourselves and our families, really, ultimately. So that's why we're all here today. So with that, I'm going to go ahead and turn it over to Dr. Mathias.
Thank you. I'd like for us now to be a little bit more interactive and ask you, if you had a place that you would like to die, where would that be? Would it be in your own home? On the ball court? Maybe in a stadium? When you're camping? Flying down on seas as if you were an Olympic star? Where would you like to pass? You know that most of us pass in a hospital. So 75% of all Americans die in a hospital. How many people in the most recent poll want to die in a hospital? None. So we see here that actually 83% say that they look forward to dying in the place of their choice. And I found out actually through the Annals of Internal Medicine in 2011 that doctors don't die in hospitals. And after working in hospitals for most of my career, I asked why. because I saw a lot of death in hospitals, from the pediatric unit all the way through ICU, in hospice and palliative care. So I was asking these questions and realized that they have a better option. Then why can't we offer that option and make that available for all who choose to die in the place where they want to die according to their wishes? So that's what really prompted me to do more research in this area, and that's why we'd like to share this with you right now. I do want to go through a process here, though, with you on taking a look from all perspectives, and especially from a faith perspective. So I have worked with Catholic hospital systems my entire career in Canada, with the largest healthcare system, Catholic healthcare system there, and then also here in Illinois. And what I'd like to share with you is we have what's called the Advanced Directives in End-of-Life Care with the Healthcare Directives for Catholic Services. And I'll explain this to you in a little bit more detail here. So you'll see that, again, 26% of people in the U.S. have advanced directives, and that's the most recent stat we have. So again, we're very ill prepared for the type of process that we all desire. How many of you have been on vacation recently? Okay, good. See several hands go up. That makes me very happy. That's good life balance. We realize that when you go on vacation, that you do some planning for that. That you take time, especially if it's going to be a long vacation. You make sure that you have all your itineraries set up, your travel plans, your insurance, everything you need to have a good outcome. We're not doing that with our end-of-life decision making. And so these tools will help you do that and begin the conversations amongst yourself, mainly, but then with your family members and friends on how we do that, how we have a really good, best death experience. Now, I wouldn't recommend that you actually talk with your family members over Christmas dinner or Thanksgiving dinner about the issue. I don't think it's wise to say, would you please pass me the potatoes? And by the way, I want to tell you how I want to die. That's not a very good conversation starter under those circumstances. But there are better ways to do that. And if you have time, make the time to actually have those conversations with your family and friends. It will mean the world to them. As a matter of fact, when I was in Canada, I had a case where there was a very elderly individual, gentleman, suffering from all kinds of comorbidities. And he had a very large family. He had 6 daughters and 6 sons. And so we used to tell him they needed to make a movie, about their lives together. He wanted to go ahead and pass without any extraordinary care. And his daughters felt that that was really inappropriate, that because we had the care, that he needed to have all kinds of care given to him. The brothers in the family very much disagreed with that. So they said, no, you don't know Dad as well as we. We've been out hunting with him. We know what his preferences are. He would never want to be hooked up to tubes and have a horrible experience, suffering so much as he went through the dying process. But the daughters felt that because of their faith, they were Catholics, they felt that they must do this in order to save his life, to make it to the very end, every inch possible, every minute possible for him to have life. So they didn't understand that the Catholic perspective does not uphold that principle at all. So with that mythology, we've been on the road to help correct that. At the end of that scenario with that family, they were divided. The father died. He died basically under the son's prerogative. The sisters were very upset, and there's still today a division in the family. So we see these kinds of repercussions. What we want to do is help diminish those repercussions and make sure that everyone has the best death possible. And that means the reverberations throughout the family, throughout your community. So we see here with that slide that only 26% are prepared, and that a good death actually involves these principles. Identifying the clear decision makers if the patient cannot make the decisions, understanding how the dying process will proceed, and we know that very well with palliative care and hospice care. We can tell you, depending on what your prognosis is, how long it will take you to die. We're pretty much on target with that. Every once in a while, I'll give you another example. My father had vascular dementia and Alzheimer's. And so he went into hospice care, and we thought that within about 6 months, which is the prerogative for hospice care, 6 months is the diagnosis for you to have for the rest of your life, that he would be gone. 6 months passed, he was still alive because of all the good care we were providing for him. We brought him home. I have a very large family, and we had round-the-clock types of my aunts, my uncles, my cousins, everyone, my sisters and brothers. We were all there to help Dad. My mother also was a retired anesthetist, so she was very good, a major care provider. So after that 6 months, he was doing so well, he came off of hospice. And then it took about another 15 months before he finally went back into hospice. Those were the most blessed times of our lives. It really brought our family completely together, and actually we celebrated every day we had with Dad. Dad was not suffering. In hospice, there's good pain management care. He did not suffer. So when he finally passed, it was a celebration. Yes, we were all grieving. Yes, we were all sad. It was a joyous occasion, and we hope that can be the same for you and your family members. We also have to have one's financial affairs in order, controlling the place and the timing of one's death. If we're so blessed to have that opportunity, we realize that that's not the case for everyone. Resolving unfinished personal business in one's relationships, how important that is. Again, you saw in the video how people had regrets. They didn't have time to actually close those open holes, to actually say the things perhaps that needed to be said, to form those relationships on an ongoing basis after the person has even passed. So we see palliative care and hospice care. We recognize that palliative care is a continuum of care. So this provides the care based on the prognosis of the individual, diagnosis and prognosis, as to how to best meet their needs as they pass through this continuum all the way through hospice care. So palliative care is part of hospice care. Palliative care deals with a continuum again of all these different types of perhaps continuing chronic conditions, and then when you get to hospice care, that's when you are diagnosed by two physicians as having only 6 months left to live. It is a beautiful continuum of care, and it can be very seamless if you understand how it works and the resources you need to have with you to help make sure that it happens in the best way possible. So recognizing it appropriate from the terminal diagnosis, when the prognosis is uncertain. We have many patients like this every day in the hospital. Hospice care centers on supporting the patients with a life expectancy of months and basically not years. So again, short window here. We're really focusing again on good symptom and pain management. Then we get into the ethical and religious directives for Catholic healthcare services, or what we commonly know in the industry as the ERDs. And they affirm the ethical standards and norms in healthcare practice. So we abide by all that is the standard practice of care. Then it provides professionals, patients, and families with principles and guides for making decisions, hard decisions, decisions that nobody wants to talk about, that nobody feels comfortable talking about. And I'll give you an example. I've had in care planning with patients and families, we'll have a team of individuals around the table from, say, lawyers and all kinds of specialists. And seemingly what we get is, the first question is, well, what's the legal prerogative here? The documents that we're going to be viewing in just a few minutes will actually show you what those are to help protect you and your loved one or loved ones when you go through this process. But what we continually got was that there was no one coordinating the care, that everyone was in their own silos, and that's what's happening in our fractured healthcare system today. We have a lot of silos, specialties, but there's no one there to bring it all together and to say, who's on first? Who's doing this? Who's providing? Where are we getting this resource from? How are we coordinating all this for the best interest and the best outcome of this patient? Today we hear about the individual who was let go just recently. She was let go in Baltimore. A patient was released from the hospital, the emergency room, and she was let go in her hospital gown and her booties. Anybody see that story? Okay, some of you did. It was quite shocking, recognizing that this woman could not speak and possibly was homeless. So recognizing, we've got to make sure we care for every individual that comes through our doors, every patient we have, meeting their needs under their circumstances based on their decision-making capacity. Obviously, this woman didn't have decision-making capacity, so we need someone to substitute judgment for her. So there's a process to do that, and the tools that we have, we'll show you in just a few minutes, will help with that. Someone in the hospital there could have asked other questions and could have actually enabled a whole process to take place for the best outcome for that patient in Baltimore. So pain management ethics looks like this. And these are the individual, by the way, there are 72 ERDs, and they cover from beginning of life through end of life scenarios. So I'm just going over 4 of them today, about 5 actually, to give you an example of how this actually applies to end of life care. Number 27, number 32, number 33, and number 61. ERD 27 says, Free and informed consent requires that the person or the person's surrogate receive all reasonable information about the essential nature of the proposed treatment and its benefits. Does this happen? Do they get automatically then the risks involved of the procedure or the medications, the side effects, perhaps even the consequences? What about the cost? And we say, just like we heard in the video before, so this is America. It's available to all of us based on all kinds of attributes we have as American citizens, recognizing that there is a limit to costs, right? We do a lot of charity care in our Catholic hospital systems, millions of dollars every year, and I'm sure with other healthcare systems they do the same, but it's different on taking a look at what our conscientious appropriation of these resources is to meeting the needs of the greater good, meeting the needs of the patient in particular. How do we balance all of that? Cost is essential. And I'm not talking about just the physical cost. I'm talking about the cost to the entire healthcare system. We've got then any reasonable and morally legitimate alternatives, including no treatment at all. So is it ever actually proposed to a patient that, these are your choices if you have no treatment at all, that these would be the likely outcomes for you? How well are they guided through a process like that? Again, is it really free and informed consent that they're experiencing? ERD number 32 says, while every person is obliged to use ordinary means to preserve his or her health, no person should be obliged to submit to a healthcare procedure that the person has judged with a free and informed conscience not to provide reasonable hope of benefit without imposing excessive risks and burdens on the patient or excessive expense for the family or the community. Think about that. Just because we can use all this technology, does that mean we should use all the technology available to us? Does it actually promote the best outcome of death? Do you realize that of all the developed countries in the world right now, that we think we have the best healthcare system in the world? That is not true. Out of 50 developed countries in the world, we are at number 50. Why is that? Everyone would say, yes, well, we have the best health, we have the best research, we have all this money. There's nothing that we can't do here, right? We are number one in research, yes. We are down at the bottom of the list, actually, in healthcare outcomes. Why is that? Is it possibly patient compliance? Again, our fractured healthcare system not meeting that the totality of the individual? There are all kinds of issues here. But we have to keep in mind that just because we can do it doesn't necessarily mean we ought to. Is it really in the best interest of that patient in the long term, not just the short term even, but long-term consequences? And what about the effect on the community? And not just the family, but the entire larger community. ERD number 33. The well-being of the whole person must be taken into account in deciding about any therapeutic intervention or use of technology. Therapeutic procedures that are likely to cause harm or undesirable side effects can be justified only by proportionate benefit to the patient. So what we're doing is constantly weighing. And by the way, the situation for a patient can change in 15 minutes. I might have just come out from a care planning meeting with a lot of specialists, and yet maybe 15 minutes later, the patient's condition has changed. So we have to come back and figure out, okay, now how are we balancing the benefits to the patient at this time versus the burdens? How do we keep that in as close a balance as possible? And not only for the patient, then, but for the staff as well as the healthcare system. Then we take a look at number 61. This one says patients should be kept as free of pain as possible so that they may die comfortably and with dignity and in the place where they wish to die. Since a person has the right to prepare for his or her death while fully conscious, he or she should not be deprived of consciousness without a compelling reason. We do accept, however, in Catholic institutions, that someone can have palliative care, palliative sedation. So in other words, if someone is in intractable pain to the point where they're not able to actually fully be at peace or healed in any way possible, they can be fully sedated to unconsciousness, thereby allowing the body, whatever mechanism is fully assaulted at that time, a chance to be at peace to heal, for the medications, for everything else to take effect, to allow that patient to have a sense of peace. In the palliative sedation, it is limited. It's only when that person is in intractable pain and no other solution, a viable solution, is available, or even has been perhaps already tried without success. So if that person's life is shortened then it doesn't mean that we or the system actually killed the patient. It means that actually we shortened the pain and suffering of the individual so that they could then allow nature's course to take over and the patient can then fully pass. So it is a fine line. I've had several cases along these lines where palliative sedation has been contested. We even had a case in Canada where it went to court. And actually, the system won the case because they recognized that this was a person in intractable pain, and no other solution would actually remedy their full, peaceful passing. So it's a process. I want to really emphasize that it's a constant communication process with the patient and all the resources available for their best outcome. ERD 61 is continued here. It says, medicines capable of alleviating or suppressing pain may be given to a dying person, even if this therapy may indirectly shorten the person's life so long as the intent is not to hasten death. We're not about killing the patient. We're about allowing that patient to pass in a very peaceful way. Patients experiencing suffering that cannot be alleviated should be helped to appreciate the Christian understanding of redemptive suffering. What is that? What is redemptive suffering? It's all about being able to offer whatever suffering the patient and even the staff oftentimes is experiencing because of that patient for others who are also suffering. In other words, in communion with them as they journey through a similar process. So it's not about all of a sudden that you become a saint because you're offering all your pain and suffering up for other people, but that is a process by which saints are made. In that sense that you offer up what energy you have to others who are also, or even more so, suffering as you are. You or your family members. Artificial nutrition and hydration. And ERDs 56, 57, and 58 actually address these. We don't have a lot of time to go into 58 right now, but I will allude to that as we continue on. It says here, a person may forego extraordinary or disproportionate means of preserving life. Disproportionate means are those that in the patient's judgment do not offer a reasonable hope of benefit or entail an excessive burden or impose excessive expense on the family or community. So what I'd like to do right now is get into some advanced directives, actual documents, legal documents that you can access. And we'll make this available to everyone here, so all you have to do is go into this and then click on these links and have these for yourself. In the courses that I teach at Dominican University, the one in biomedical and healthcare ethics, I have my students actually complete these documents. They find it extremely helpful. At first, they feel like it's the last thing they want to do, and then after they do it, it's just like when I've seen people do spelunking, and they're extremely afraid of doing it. When they come out on the other side, they say, can we do that again? So it really is a blessed experience because they realize not only do they feel then more protected and empowered, but how they can serve others. I've actually had many, many students come back to me and say, I can't believe how much this helped my dad, who just passed 3 months ago because of his cancer, and how immediately important it was that she could offer these tools to help him. She said it was the best experience ever. So, and to give you another example, I just got this from, this is Life Matters Media. They do a lot of work with end of care preparation, and especially with advanced directives. And I just wanted to share a story with you. This is the senior active men of Evanston, Illinois. They just met recently, and they were talking about end of life care and experiences, and also about preparing for good deaths. And this gentleman says, they were asked if you ever witnessed a good end of life experience. This gentleman says, yes. Just 3 months ago, when his wife died, he told us why he was smiling. He says, when my wife was diagnosed with cancer a year ago, there was nothing that we could do to cure it. She said no to the other options offered, asked me instead if we could travel the world. That's exactly what we did. And I kept her wish, and we didn't tell anyone her diagnosis. She didn't want that pity. She wanted to enjoy. We returned home. A month before she passed away, we had hospice care at the house. She never experienced any pain. It was as beautiful as it could be. So grateful for that, he said, and for the process. So there are ways that we can make sure that this comes to pass. Another document that just came across my desk recently, this is on the Palliative Care webinar, In Search of a Good Death, Living Well with Serious Illness. So there are all kinds of resources out there. This is through the Supportive Care Coalition. So there are many, many who are addressing this issue around the country because we realize with only 26% of people having advanced directives, how critical it is for their well-being and also for our healthcare system's well-being. We spend billions of dollars each year on unnecessary and futile care. And actually, and my sister, who is a nurse at St. Vincent's Hospital in Indianapolis, she has told me that actually we torture patients to death because they haven't made those decisions to protect themselves and their loved ones from such procedures. These documents will help you, and as we get through them, I'll open each one up here. This is a personal decision, and the reason I chose this one is because it is free of charge, of course. This is through the Illinois State Medical Society. They've done an excellent job of pulling all of these documents together, so you can go through them step by step, one by one. And this is the link that I give to my students, as well as the Catholic link that has all the same types of documents, but from a Catholic perspective. So this one says, you'll notice here, we start out, personal decision. And it looks like this. It's very readable. It doesn't take long, actually, to go through this. Notice here it has living wills, powers of attorney for health care, mental health treatment preference declarations, the uniform POLST. And POLST is actually something that has just come through the Illinois legislature about 3 years ago. They've changed it ever since back in 2011 when I first got involved with it too. And Dr. Goldstein at Advocate Medical, she was very instrumental in getting the legislation with a whole lot of other individuals passed for us. And this deals with individuals who only have 6 months or less left to live. So again, it helps to prepare you whether you want full treatment under any circumstance, if you want a middle of the road and as we go type of prognosis adjustments, or if you want hospice care or comfort care only. And then organ donation. By the way, how many of you are already organ donors on your license? Great. So you have 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. Great. No, oh, perfect. Good. So about more than half of you. Thank you for doing that. By the way, did you know that you can actually donate over 237 different parts of yourself? So not just your organs, but tissues, ligaments, corneas, all kinds of things. So I've been telling all my family members, take it all. I'm not going to be using it in the future, so please, if anyone can use it to benefit them, please take it. So as we scroll down here, I just want to show you, because we don't have time to go through the entire documents, but exactly what they look like. Here are the contents, how to indicate your decisions, again, each of the forms, and taking a look again, the actual forms themselves. So this just gives you a background, so that you have more information about what this form actually does for you. And then some of it is its formation background as well. And then we get into, you can see each one of them. This is the Statement of Illinois Law and Advanced Directives. And here's the living will. The living will is not very long. And actually you can fill this out pretty quickly. The thing to do is to make sure you have a personal agent. So who would you like to make decisions for you if you can't make them on your own? We have numerous cases. We get homeless people that come through our doors at St. Anthony's all the time. Normatively, then we have to actually get a court order. We actually have to have go through a process by which we get a court order to make those decisions for that individual. It can take oftentimes weeks, which again is not in the patient's best interest. So, please automatically think of who you would like to make those decisions for you if you cannot make them on your own. Right now I was telling you about my sister, who's the nurse, and people would say, well, why don't you have your husband do that for you? My sister, the nurse, she's been a nurse for over 44 years now. She was voted the best nurse at St. Vincent's Hospital. She knows how to navigate the system. She knows what my preferences are. She knows what my values are, and she will protect those. So I trust her to be my personal agent. Then my husband is secondary. So, choose the person that you know will make sure that your desires are respected and upheld. So once you get through this, you have to have a witness, and the witness cannot be your spouse. Okay, it has to be someone that's not related to you, but it has to be someone perhaps that would make sure that they are a credible witness. They have to be 18 years of age or older. All the details are there in the preamble here for you. How are we doing on time, Mother?
6 minutes.
6 minutes, okay. So as we go down through these, here's the notice of the individual signing the power of attorney for health care. the power of attorney for healthcare basically protects you, it has two things, one for healthcare and then also for your financial situation. So even if you're a student right now, and let's say you have financial loans, let's say you have debt, who's going to take care of that debt if you happen to pass? That 8% of everyone, as we saw on the slide here that Dr. Roucka had for us, that actually 8% of you in the ages from 18 to about 24 will die this year. And that usually is a tragic death, some accident or perhaps some cancer. But recognizing that we all need a personal directive. We all need to have these forms filled out. You'll be doing the healthcare system and all those who take care of you the most blessed favor in the world. Because then we know how to make sure that your wishes are respected and upheld. Otherwise, it can be a long process, and you may not get what you want or need at the time you want or need it. So then we get into, you can see, again, it's not very difficult. Notice here what's most important to you in your life, how important it is for you to avoid pain and suffering. They ask some general questions. Would you rather be at home or in a hospital the last days of your life, last days or weeks? Do you have religious, spiritual, or cultural beliefs that you want your agent and others to consider? Another example for you, when I was in Canada, working there, we had the home lock unit at one of the hospitals where I served. And this gentleman was dying of cancer, stage 4. His family did not want him to know that because they said in their culture that if he learned he had cancer, that basically just said, we're not going to care for you anymore and good luck. That basically was an abandonment type of issue. So, and that they wouldn't fight anymore to try to stay alive or have the best out or the best quality of life in what time they had left. So it was very important then that we had long discussions with the family members. And so finally, after about 2 weeks with constant discussions with various members of the family, we finally were able to let them see, based on what we talked about before, it was in the best interest of him to know that he was dying. So he could have a chance actually to make those decisions so he could have the best that he wanted. So there would be no regrets on his side or on their side. So it was very blessed then to see that come together. In other words, where we had good conversation, it was difficult, and yet he felt so grateful. He said, "Thank you for letting me know. Thank you." It was just so uplifting to the staff as well, because we worked so hard to make sure that his best interests were protected and upheld. This one, do you wish to make a significant contribution to medical science after your death through organ or body donation? The other one's here. What types of decisions can my agent make? Who should I choose? This helps you with that part of the discussion. What if I change my mind? If you change your mind, all you have to do is make a cross through the documents and then date and sign it, and it's no longer valid. Then when you want to actually redo it, just get the form again and then fill it out again and date and sign it, and it's good. Now, some people actually carry, on that, don't have my phone with me up here, but they actually carry their personal directives on their phone so that anyone can access them who has the passcode, of course, especially their loved one who probably already knows that. We see it in hospital settings all the time, where it's right there. If you also have these documents ready to go, you can have them put into the hospital system where likely you will be taken if you are in an accident, say, so that they will be able to pull those up right away. You give them to your primary care provider. You give them to everyone. In Canada, there was a woman who was dying of colon cancer. She actually had her personal directives on her headboard. So she said she was in stage 4, she was imminently dying. She said, I want everybody to know that I don't want any extra care. I want to go in peace under my conditions, and they're all right here. So don't even try to keep me alive. So she made sure, even if she had copies of her personal directives, even in the bathroom right next to where her bed was, she said, in case people have to spend some time there, they have some good reading to do. So as we get down to some of these other forms, you can see again, successor of healthcare agents. So as you go through these documents, and the one even on your mental capacity, in other words, let's say that you're an early Alzheimer's patient, or that you have, or you've even seen a family member with dementia, make sure that they fill these forms out. You get those filled out with them before they get to the point where they can't. There's so many instances where we've seen where people come into the hospital and they can't find their personal directive, or they're already so demented that then we can't assess truly what they would desire. So we go by perhaps what their best friends or their family members had wanted, but we don't know if actually that's what they would prefer. So please make sure that you do this for you and your loved ones. As we go through this, then you can see here's the POLST form. And again, this is for practitioner order for life-sustaining treatment. And again, this is only used when you have 6 months or less to live. So it's very important. This goes into your chart right in the hospital, right there. So anyone who pulls up your chart can see it. All the doctors, anyone who cares for you can see what your preferences are, and then can attune their treatment of you accordingly. And then the organ donation card. So that's just one of the documents, again, through the Illinois State Medical Society. Again, one resource, I should say, of all those documents. Another one is, and these are the individual ones. Pull this up. Here we go. Here's the individual, this is the power of healthcare that I just talked about. This is the one on the 5 wishes. Have any of you ever heard of the 5 wishes as a personal directive? Okay, this document actually was made up back about 2003, and it was basically from a Jewish source, but it has become so commonly used and so popular that all religions, all faiths, even atheists use it. It's a wonderful tool because it actually goes through what your basic 5 wishes are for your end-of-life care. It's a beautiful document, so well done. We see it all the time. It's very readable, again, very accessible, and many prefer this. Even people who are providing the healthcare often prefer this document. Then when we get into the next one, again, that's the POLST form, and I just want to show you very quickly. Again, you can see that here we have the CPR, whether you attempt that or not, you just get to choose that. That 3% of all people in ICU who get CPR actually survive. A lot of people don't understand that. We see it on television, you go in and you see somebody get a CPR and they live. Right? If you go into ICU today, then only 3% of people who receive CPR in ICU today actually survive. Many of them are already so declined, in other words, that they're so fragile, oftentimes in the process that bones are broken, chest bones are broken, which causes the patient to get more pain and suffering. So oftentimes it's not worth it. I've seen even physicians in several of the hospitals, they refuse to do that because they know the consequences to the patient are not in their best interest. So they refuse actually to give CPR under those circumstances. Now, if you have a 40-year-old man with 3 children, likely to survive, have a good quality of life afterwards, yes. But oftentimes when patients are already so, with comorbidities, so declined that it's just not worth it for their best interest. So just there we have, again, the POLST. The final one was the organ donation. And now I'd like to just open it up. If you have any questions for Dr. Roucka or myself, any experiences maybe that you'd like to share with perhaps your own personal loved one,